My name is Marie McGrath and I'm one of the technical directors at the Emergency Nutrition Network. And I've been working on the area of MAMI, or Management of At-Risk Mothers and Infants Under 6 months, to give it its full title, since around 2007. And about a month ago, I did an informal update for my ENN colleagues about the work we've been doing on MAMI with a part as a bigger collective. And a few of them said, why don't you share it outside ENN? So here you go, and here it is. So it's a bit of a whiz through the history of MAMI at ENN and outlines some of the principles of our work, some of the work we've been involved with, and some of the directions of travel. It's a reflection not just on ENN's work, but that really of a much bigger collective of individuals and agencies who really have galvanized and worked and catalyzed programmatic and policy and research over the last 10 years ago. And so I want to really acknowledge the collective effort that I'm representing here. This is not just ENN. We're just in a very privileged position to be helping to facilitate and coordinate this. And particular mention to Marco Carac at the London School of Hygiene and Tropical Medicine, my partner in crime, as it were, on MAMI for many, many years. And to the teams at Save the Children and Goal and MSF, who really have been catalytic on an operational level in bringing about change and bringing about pragmatic, practical direction to what we do, and to researchers like Jay and Martha Khalifi in Kenya, who really have driven research and development around anthropometric and other assessment of at-risk in infants under 6 months of age. And also, I would really like to say big thanks to our funders who really have kept the MAMI show on the road at ENN for many years. In particular, acknowledgement to Irish Aid, who have made a huge difference to us, and as a result, a huge difference to this collective and the change and evolution, and I hope indeed the revolution we're going to see in MAMI is very much thanks to that continued and well appreciated support. So enough of that, and without further ado, I'll give you a little whistle-stop tour and a taste of MAMI at ENN. Yes, so MAMI began back in 2007, and a lot of NGOs were highlighting challenges in managing these kids in their programs. They were saying, we know they're not supposed to be in our programs, but we're admitting them and we're not sure what to do with them. And this was coming out through case studies that we were doing as part of some IFE work. So that prompted the MAMI project, and what we call then the Management of Acute Malnutrition in Infants Under 6 months project, which is a 2-year project that was funded by the cluster and the nutrition cluster at the time. And we investigated the global burden of acute malnutrition in this group. We examined guidance and tools. We looked at how cases were being managed, and we gathered data around program outcomes. And it was mainly secondary analysis and qualitative research. And we formed a sort of an expert group to inform us. And Marco Carac was the lead researcher who was at UCL at the time. And he was a lead researcher, and as many of you know, he has stuck with MAMI ever since. So that was sort of the origins of the MAMI project, and I'm just going to touch on a few elements of what it brought out in that big report that we did, as it set the scene for our work. So one thing we did is we looked at 21 country DHS data sets of high burden countries, and looked at what the burden of wasting was in those countries. And when we extrapolated those 21 country data set findings to an estimated 55.5 million infants under 6 months in the world, we found a considerable burden of wasting. Particularly when you transitioned to the new WHO growth standards from the NCHS references. So in terms of severe wasting, we had an estimated 3.8 million infants, moderate 4.7. So all wasting about 8.5 million. So a considerable burden. And one of the questions that we'd asked at the time was what we were seeing, just something that was specific to humanitarian contexts and these pockets of particularly fragile areas, or was this a global burden? And this was reflecting, this is actually a global issue, and that we aren't really spotlighting. And we also found that when you transitioned from the NCHS references for the growth to the WHO growth standards, infants under 6 months made up a greater proportion of the severely wasted caseload. So that again was sort of a significant thing that was going to come up. And we actually, in collaboration with London schools, subsequently updated this analysis. So where we'd only done 21 countries and had just looked at wasting, in 2008 we updated this, and we looked at underweight, wasted, stunted and low birth weight, and in 54 countries, so all countries which had the necessary data for infants under 6 months of age. And as you can see, there's irrespective of what indicator you use, and we're increasingly looking at underweight to identify at-risk infants. The burden is considerable, and the average prevalence, for example, of wasted is 21%, underweight is about 20%, but it varies greatly by context. So again, reinforcing that this was a global issue. We also, as part of the MAMI project, we looked at existing guidelines, and we did a review of, well, what guidance exists. So we pulled together lots of national guidelines, agency guidelines on severe acute malnutrition management, and we critiqued them using the AGREE criteria, which is a framework used by WHO. And we found that inpatient care dominated case management, which was no surprise, and there was no community-based option for these infants. And admission criteria varied. So irrespective of whether a child presented severely wasted or whether the mother presented saying having problems feeding, they all were admitted as inpatients. Anthropometry was based on weight for length, because that was recommended by WHO. There was no MUAC for these age groups, although MUAC was measured for some kids. And supplementary suckling, which is where you breastfeed an infant and then you give either express breast milk or a therapeutic milk formula through an NG tube into the baby's mouth to sort of re-establish feeding. That was the mainstay of treatment. As I say, it was all inpatient. What we also did was, because programs were admitting these infants, we then wanted to see, well, what was happening to them. And a lot of them were unofficial, so they weren't included in routine data. But we did manage, by hook or by crook, to pull together a load of data that programs were gathering, particularly Action Against Hunger and MSF. And we looked at the outcomes of these infants under 6 months of age in the program and compared it to the outcomes of children over 6 months of age who were in the same program. And we found overall there was a significantly higher infant mortality for these infants than compared to children, even if they were treated in the same program. Half of the countries had a mortality rate of less than 5%, and a third had mortality rates of 11 to 20%. And we published this paper, but we had no information, and we couldn't determine whether this was just due to a residual higher risk that younger infants have, and so they're at more risk of death, or whether this was related to how they were being managed or how they were being presented. And there was no contextual information in terms of prevalence of acute malnutrition in the population, or confounding factors like HIV and clinical status. So this really was rough program data, but it just, again, it spotlighted an issue and sort of the problems and the challenges around case management. And indeed, there was no active case finding. So often these were kids that just presented and may have been on the more extreme spectrum. But that's a few of the snapshots that sort of paved the way. And really, we came out of the MAMI project with a really long list of questions, and really it opened a can of worms, really, when it came to these infants. And so for us, we said, well, how are we going to handle this? And as we came and were sort of reflecting at the end of the project, we came across this Vermont Oxford network, which is around newborns. And a lot of the issues that they had about trying to build evidence resonated with how special care units, baby units and premature infants, etc., really struggle to gather and develop evidence. And they had formed, because you can't really experiment them in the same way, or they're a very high risk group. And so this Vermont Oxford network was a global network that coordinated and shared research, documented potentially better practices and outcomes. And we imagined, wouldn't it be fantastic to have some sort of global MAMI network where we'd have collective, collaborated, harmonized efforts around research and policy to inform practice. It would connect and reflect national and global priorities. You'd have well-designed research with people talking together, harmonized data and real-time active learning. And that's how we formed a MAMI special interest group. that emerged from that, that the kind of the peer group that we had involved in the original MAMI project. And it started with about, I think there's about 6 or 7 of us around the table. And really it's developed into an informal network of researchers, practitioners and experts whose ambitions are to harmonise and collaborate on policy, research and programme. And our guiding principle is very much addressing what hampers programming and programmers and frontline practitioners at levels, whether you're at government, whether you're at an NGO level. And we encourage and really try to nurture some active, strong collaborative partnerships and experience exchange. And how it's worked in practice is, again, it's very informal, but though has evolved, and I'll talk a little bit about that in a bit. So we undertake pieces of work to get for the group. Some initiatives are member led, so or consulted on. So, for example, some of the team may take on pieces of work that contribute to the group, or maybe undertaking research that is very relevant and will share it and look to the group for some peer input. So it's very much has been very iterative in terms of how it operates. And one of the priority actions we did when we formed this group was that we had such a long list of questions that we really needed to start to prioritise them. So we undertook a chinry, which we published, around MAMI priorities. And the top 5 questions were, firstly, how should as it was configured then, severe acute malnutrition be defined in this age group? Second was, what are the key opportunities or timings to incorporate with other healthcare programs? Third, what are the priority components of a package of care? Fourth was efficacy of providing targeted skills support. And then the fifth is, how can we existing tools be adapted or linked? So these were the top 5, and really these have been sort of really guided and helped frame the work of the collective since, and what we have focused on. And just to highlight, there's been a couple of more recent chinries that have been conducted by ENN or involving ENN. So there was a wasting treatment chinry that was conducted by No Wasted Lives and Cortisam in 2017, and that's shortly going to be published. And the number 3 priority there was, what are effective and safe strategies and protocols to support scale-up of treatment in infants under 6 months of age. And then the wasting chinry that ENN undertook, and I think has just been accepted for publication. The number 1 global priority on that chinry was, what is the impact of interventions for managing at-risk mothers and infants less than 6 months of age in preventing wasting in this age group? And number 2, what is the impact of growth failure during the first 6 months of life and experience of wasting of acute malnutrition after 6 months of age? And these questions very much resonate with what we're examining and have been examining in the MAMI group. And this whole area of growth failure was the exact topic of a meeting that we worked with WHO at the beginning of 2019, which was configured around growth failure in infants under 6 months. And again, even further down, number 6 and number 7, very related factors around priorities around pre-pregnancy maternal factors and determining risk of being born with a low birth weight, which is one of the key actions that has come out of our recent MAMI meeting. And again, what anthropometric or non-anthropometric measures best identify infants? And again, that's an area that we're actively examining. So we are picking and touching, and it's easy to, and it's interesting to see how infants under 6 months have really raised are getting much higher profile, the fact that they're coming out in these global prioritization. One area of evolution that we have seen over, and as we've learned over the last 10 or more years on MAMI, is we originally framed it as management of acute malnutrition in infants under 6 months of age, which reflected the origins of where it came from and what sparked the MAMI project. However, you know, as we've learned, it's not just about acute malnutrition, and really it's about management of at-risk mothers and infants under 6 months of age. And so we kept the acronym, but we changed how we described it. And it really puts mothers and infants as a core dyad that we really can't even attempt to manage and understand what's happening with an infant under 6 months who we identify anthropometrically or with other means as at risk if we don't look at the health and nutrition and well-being of the mother. So this very much reflects that. And it also reflects our evolved thinking that anthropometry isn't a diagnosis in itself. It's an indicator of risk, and which may be nutrition, but it may shouldn't relate it, but it may be other factors too. And so that's why we're framing it much more in terms of at risk rather than malnutrition. And there is a risk of just labeling infants who are small as malnourished, but also it risks seeing the interventions required as only nutrition related, as malnutrition tends to be associated with being malnourished. It tends to sort of encourage you to just think about a nutrition intervention, whereas actually the interventions are more broader. And so again, that's reflecting a more holistic approach to this age group. Since over the last 10 years, we have seen considerable progress. A key target we had coming out of the MAMI project was to target normative guidance, WHO guidance, and we're actively involved in background preparation and work for an update that happened in 2013. And so that update of SAM guidance at WHO for the first time had a chapter on infants under 6 months, and for the first time recommended community-based management for uncomplicated cases. So that was a significant change. And so it gave license for community-based management for these infants. And so WHO also convened a meeting, as I mentioned, on growth failure in infants under 6 months of age. That was very much informed by the work and thinking, and us really encouraging them to move away from this SAM and actually think of more at-risk infants and about more growth failure. So this was about 55 or so people got together, across researchers, programmers with country representation, and across neonatology, pediatricians, humanitarian and development. And Tamsin actually was at that meeting, and we did about 6 or 7 of the background papers that fed into that meeting, and also documented the meeting for WHO as well. So we really have enjoyed a very active and strong relationship, and have definitely played an influencing role with WHO in terms of their direction of travel. In terms of programming, I'm going to speak and touch a little bit on the MAMI tool in a bit and explain a little bit more about it. But we definitely have seen an upsurge in programming facilitated by some of the work we've done on that in Ethiopia, in with Goal, in Bangladesh, led by Save the Children, both in terms of in a development setting and in Rohingya, in Rwanda with high-risk groups. And it's also been actively explored in Afghanistan, in Somalia, Philippines, South Sudan, and we're in the early stages of looking at how to integrate the MAMI approach in India as well. So it's a very dynamic area. We're constantly now contacted by agencies saying, we're wanting to do MAMI, how should we do it? And some of the agencies that are particularly invested in it are Goal, who have had programming going for several years in Ethiopia in a refugee context, and Save the Children in Bangladesh, who've just appointed a MAMI advisor funded by OFDA, who will be sort of in a rapid response team model, where they'll be able to be deployed to countries to help support where countries are looking at integrating this approach, or trying this approach, or piloting the approach, and also desk-based activity to support the work of the MAMI Special Interest Group. And in part of this, as well as being research. So again, Save the Children have undertook research in Bangladesh, and ENN collaborated with them on this. Goal are undertaking research in Ethiopia, Action Against Hunger in Mali. And so these agencies have all connected into the MAMI SIG and have shared what they're doing, shared protocols, and we really tried to help align things. So there's been progress, but in terms of the state of play, a significant constraint has been the lack of uptake of the 2013 guidance on community-based management that I said was made in 2013. And we did a review and updated several times of national guidelines, and we did one we updated about a year ago. So we took 48 national guidelines for severe acute malnutrition management, and we reviewed what was case management involving now. Was there uptake of in the 2013 guidance? And still we found that inpatient care dominated, and out of 48 guidances, none of them had integrated community-based management. And 3 of those countries, so Malawi, Sri Lanka, and Ethiopia, there were actually people engaged with the MAMI SIG who were at country level really advocating for making the case for community-based management, drawing on the learning we had. And we were in direct contact with them, and they would go so far and then they would never go. When push came to shove, they were like, no, we don't want to go into community-based management. We're going to stick with inpatient care. So we did, ENN did a detailed review, sort of case study of these 3 countries, which we published in Field Exchange, to examine, well, what were the barriers to policy change with these infants at country level, and did interviews with those involved, including government. And what we saw was a real demand for robust evidence in order to make that leap into community-based management. They wanted to know what interventions work and how in different contexts. Critically, how do we integrate within existing systems and services like community services, reproductive health, neonatal health, pediatrics, CMAM? What are the implications for the cost and capacity at government level? And is this approach scalable and sustainable? And these are very right questions to be asking, and you could see exactly why they weren't kind of moving along. I think another reason as well that came out was that because inpatient care had dominated, many of those convened around the guideline development at country level were clinicians, and they saw the more extreme cases, and they were fearful of moving to community-based model because they're thinking, how would we manage those cases in the community? It would be high risk. What they weren't seeing is the many cases that were uncomplicated and much more on the lower end of the spectrum, who were starting to decline and starting to growth fail, but weren't yet sick and presenting. And so again, there was the lens that they were using was very much the extreme cases, and we were really making the case for the more uncomplicated, lower risk infants to be managed at community level. And limitations that the countries were describing very much reflected the limitations that came out of our discussions at the 2018 MAMI Special Interest Group meeting, which we reported on, and indeed Tamsin did the report on this too. We had a lot of technical discussion around identification, around indicators and integration with other services, but a big limitation to progress we concluded on was robust evidence of what works and how it works. And an urgent action we identified was to develop a randomized controlled trial and case control trials to test MAMI approaches, because we were getting pockets of pilots and operational research by NGOs, but these weren't getting at the heart to sort of robust research. So we did spend about 2.5 years out of that meeting, really from 2018, really actively pursuing the potential for a decent randomized trial. And we had a few failed attempts, but thankfully we got there, and we now, led by Marco at the London School of Hygiene and Tropical Medicine, secured funding for what is a 4-year programme of research funded by the Eleanor Crook Foundation, and it's a collaboration between the London School of Hygiene with Goal in Ethiopia, with Jimma University in Ethiopia, and ENN. And we're in we've started now, it's a formative phase of about 1 year. And then it will progress to a randomized trial around September or so this coming year. It's in 2 areas, in Jimma University, sort of support healthcare clinics in the Jimma zone, and then in Hadar, in another region in Ethiopia, where Goal are operating. And just to give you a flavour, so it'll involve, it'll target infants under 6 months of age, where they will get a rapid screening, MUAC, weight for age, and a few other non-anthropometric indicators at every healthcare contact point in the community, whether it's an immunisation clinic or an under 5 clinic, and we'll likely be using some family MUAC too. So really using the leverage points that exist within the existing systems. If they're identified as not a problem, they'll get reassurance, and then if they're at risk, which we're estimating would maybe about 10% of the infants, they'll get a full sort of MAMI assessment modelled on the MAMI tool at the nearest health centre, and they will then be randomised to either standard care, which is currently inpatient referral, or a MAMI package of care. And we'll be looking at outcomes at 6 months of age, and at 12, 18 and 24 months of age as well. So long-term follow-up. And primarily we're going to be looking at anthropometric change at 6 months, but we're also looking at important secondary indicators like breastfeeding indicators, body composition, some development stuff, maternal mental health, etc. We're working very much closely with the government of Ethiopia on this, and we had a trip out in October where we had key stakeholder meetings at DEDR, at JIMA and at ADIS levels to share our ambitions and thoughts and to get co-creation and input into this right from the start, because we're looking to influence policy in Ethiopia, Ethiopia. And practice, and very much looking at how we integrate scale up considerations from the very beginning. So it's a very exciting, interesting opportunity for building some evidence on this age group. I'm just going to mention it because I've mentioned it a few times, is the MAMI tool. So during our maybe 2016 or so, as there was increasing attention to infants under 6 months of age, and people were saying, yes, we recognize this as an issue, but actually we still don't want to keep looking for them, because if we find them, we don't know what to do with them. And so we thought, well, it's not as if there's nothing out there. There's actually breastfeeding tools, there's IMCI for clinical case management. Really, let's see if we can pull this content together in one place. And to give something in the hand of practitioners, so they have something to start with, and that will hopefully catalyse programming development, because we need to do something, and practitioners are saying we need to do something with these infants. What can we draw upon? So what we developed was the CMAMI tool. And basically it pulled together resources. We framed it around, and essentially it's a care pathway. We developed a checklist on it for assessment, then how to classify and how to manage, and built-in resources to help in case management, which is, in this checklist sort of manifesto, is used in a lot of health system approaches and health pathways. We modelled it in terms of approach and formatting it in the form of IMCI, so that it resonated and could link in with the integrated management of childhood illness packages that were existing at country level. We integrated support for the mother as well as for the infant. And it really allowed for more individualized, tailored interventions. So we developed that tool, and we then updated it in 2018, I think it was, based on experiences of using it and feedback, and an evaluation of the tool that was conducted in Bangladesh in terms of how it was used. And again, this is an example of the sorts of materials that are used or integrated with it. So you might have a checklist where you've got classification, and then it will bring you to a resource or a section to actually practically help you. And we've integrated some very interesting global health media videos, which are great content that have been developed by the Global Health Media initiative around support. And we are now updating this MAMI tool to version 3, which will form the basis of the trial in Ethiopia, which will test it, and so there'll be the opportunity to pilot. And Kelsey, maybe you could just say a few words, because you're leading and really helping on that. Maybe just say a few words about what you're doing with regard to this.
So I've just started by doing a scoping review and looking at other patient management tools across nutrition and health, just to get some inspiration for if there are any designs that we think could be more effective, different formatting to increase user friendliness, and also looking at just evidence of what tools are effective, what is the actual evidence behind their implementation, and bringing that together. And first impressions so far is that often there's very limited evidence that many of the tools that are commonly used have actually had a large impact, and that overall there really hasn't been a lot of research that's been explicitly talked about anyway. They do talk about field testing the tools, but not explicitly looking at like elements of design that would make it more user-friendly, or would make it, better, just let practitioners have an easier time of identifying and assessing many infants. So I've come across some interesting tools that will incorporate into next steps and come up with some prototypes so that we can then put those out to the special interest group, a kind of a core group who are going to consult with us and guide where we want to take the tool for the next draft. Yeah, so hopefully we'll have some working drafts well before spring, summer, so that those can go and have some a bit more qualitative research and input before the tool is used in the RCT.
Great, thank you, Kelsey. So our vision at the moment with around MAMI is that every infant under 6 months of age at every community or health service contact is nutritionally assessed and appropriately supported to survive and thrive. And like the survival agenda certainly hasn't been delivered on yet, but we feel that an ambition, survive is really not dead, and we feel we could have a bigger ambition than a child not being dead. So we really want to look at the thrive component as well, and the longer term implications for development, and indeed way on into non-communicable diseases and the implications of early nutrition and support and treatment have for the long term for children. And just relocating it very much exists in the sort of first 1,000 days of life is a window of opportunity, and there's been a real gap in terms of what happens around the 6 months of age, and that straddling between neonates and then up to 6 months of age. In between, there's been much less attention. And in the short term, as I say, we're looking at survive and thrive, and long term, really looking at the consequences for non-communicable disease and mental health too. And really, we see both it straddling both prevention and treatment. And really look at it all as in terms of prevention, where at a primary level, primary prevention is where you're preventing disease occurring and preventing something happening. Secondary is you're treating it. So this is where there's now a problem. You're treating it, but you are preventing a further deterioration. And then once you get down to tertiary level, this is where you're preventing really adverse outcomes like disease, quality of life, and indeed death. And we very much see where sort of IYCF and MAMI straddle. Infant and young child feeding is really more at the health promotion level, more at the primary level, where you've got sort of a blanket targeting. You have, one person having contact with many, and these tend to be low risk infants. Whereas MAMI is much more straddling the secondary area of sort of treatment and prevention of further deterioration. So it's a more targeted intervention, would involve more one-to-one contact, and these are infants that are at moderate risk. So that's just where we see the sort of interface between infant and young child feeding and MAMI. And then at the tertiary level, you have the more clinical inpatient intervention. We're very much modeling the MAMI approach and really leveraging and looking at existing health systems, which begins, and in terms of the ecosystem, it begins in utero and goes onwards. Now, we are focusing at the moment very much in this 0 to 6 months of age group, but with a view to expanding our attention to the maternal nutrition, and that's an ambition as of the MAMI SIG as we go forward. But at the moment, there's so much to sort still with the 6 months of age. We have sort of focused in there. But antenatal care is a critical point, particularly in terms of reducing low birth weight infants, who are essentially infants that you pick up as wasted or stunted or underweight. The missed opportunity often in terms of weight for age at birth. Increasingly, infants are being born at facilities, and there are increasing opportunities to identify underweight infants that are born and to start action early on. And then there are other avenues with the PI where you have vaccination points, growth monitoring programs. These are all opportunities for screening and for intervention for these infants under 6 months of age. And this is where we really see the leverage points. And this has been reflected in some of the research, so sort of secondary data analysis we've done, looking at risks, anthropometric indicators, and which ones identify infants most high at risk. And what we've done is looked at what in anthropometric indicators at birth and at around 6 to 8 weeks of age. So when a child will be coming for their first vaccination, if you were to screen then, what anthropometric indicators would identify an infant at higher risk of death? And we're finding it's weight for age and mu at top, and weight for length is useless. You also, the other contact points in the first month of life is if a child presents sick, an infant presents sick, and again, what are the opportunities that they don't just treat the disease, but they actually do a screening. And so these are the sorts of things that we are reflecting in our MAMI tool, in our MAMI approach, and which we'll be testing out in Ethiopia. And there's also, when it comes to interventions, there's a sort of a risk-benefit balance between what is a high risk intervention and high cost program and a low risk. So if you've got a high risk intervention, you know, you need to be quite specific, and you kind of compromise on the sensitivity. But if you've got a low risk intervention, which is relatively low cost, then you can afford to be sensitive. And we are very much erring on the sort of the low risk component of where the type of intervention we are involves sort of targeted feeding support, both for breastfed and for the non-breastfed infants, and then ensuring access to quality health care, making sure kids are vaccinated, making sure that they get appropriate disease management, and then assessing and dealing with health issues for mothers, including maternal mental health. Again, we are seeing and using anthropometry not as a diagnosis in itself. And so in terms of how things tend to be in the nutrition world, we'll have sort of an anthropometric deficit. Say if you take, for example, low weight for height, or indeed low BMI, it's describing a process of wasting and the state of wastedness. But then we leap into, well, that child's acutely malnourished or chronic malnourished or whatever, and we label them as a diagnosis. And really what we're doing in MAMI is where this red line is, we're not making that leap. So a child, we're really saying this anthropometry indicates that an anthropometric state, but it's not a diagnosis in itself. And what's much more important and relevant is functional outcomes and what are the consequences. So that really reflects our thinking about at risk, and it also is not, you know, linking and making a judgment that it's just related to nutrition. And I think it just reflecting this thing about the limitations of anthropometry, and within the example with infants under 6 months of age, if you've got an infant who has a weight for length, for example, of less than -3, that should be less than -3 there. So low weight for length, are they severely malnourished, are they severely wasted, are they malnourished, or all the labels that would normally be applied to them. You might have an infant that's small, but if you take one just measure, they might be small but actually growing well. It tells you nothing about the trajectory. Or small and not growing well. Like you can have a child, an infant who is big, or you know, doesn't meet that criteria and is not growing well either. So you know, it doesn't pick up on that. Then when you start to unpack further, well, do these cases need the same management? So somebody, an infant that's small and not growing well, it may be due to a failure around breastfeeding, but it also may be underlying disease or disability. You unpack further, and maybe different degrees of breastfeeding compromise and support needed, and different types of underlying disease. You can have all manner of complexities, none of which that simple anthropometric indicator will have given you. And you still have got those infants who are small but growing well. And there's a risk of labeling an infant as malnourished who is actually doing fine, and starting to intervene or encouraging interventions that may be inappropriate. So this is really why we really are nuancing anthropometry. It has a role for sure, but it's not does not give you the whole picture, and does have risks associated with how we tend to treat it as an indicator in the nutrition world. Really, our opportunity is really with MAMI is linking services, nutrition, health, mental health, social services, early childhood development, and sort of environmental and physical areas. And now I'm going to quickly, I know time is whizzing by, but I'm just going to conclude really with where we got to at our MAMI Special Interest Group meeting in Brussels recently. was co-hosted with MSF, which was a great collaboration. And our ambitions of this meeting was to propose a clear direction of travel on a common vision and terminology for MAMI, indicators to help identify at-risk infants, and then collection of standardized MAMI program data. We had 47 participants and a waiting list to attend. And we had neonatologists, maternal health specialists, pediatricians, nutritionists covering research, programming, clinicians from NGOs, several donors, including USAID, and a really dynamic, engaged group. And in the opening session of the meeting, many, when we did our sort of introduction, said, "Oh, we feel like an outsider here. We're not nutrition." And I was like, "Thank goodness, finally." It really was a mixed collective across sectors, and really a dynamic meeting. And we put country perspectives at the heart of the meeting, and we started with a conversation with stemming from representatives, Sinuel from Ethiopia representing Ministry of Health, and then a pediatrician working in the hospital in Malawi with inpatient care, and then perspectives from India from a Ministry of Health and UNICEF there. We then had sessions on implementation experiences, and again, rather than death by PowerPoint, this was a panel discussions and conversations with plenary and with about 8 representatives of different practitioners who've been working with these infants and managing programs from Goals, Save the Children in Malawi, research in Kenya. We had sessions then on building bridges across stakeholder groups, maternal and neonatal health, which was represented by WHO, who called in early childhood development from WHO, and then maternal mental health as well. So again, looking to how we bridge and looking what practical initiatives and tools and leverage points have we got with these other initiatives. We then had a session on evidence where we had WHO telling us in terms of where they're at with policy and guidance and what direction it's heading. And then we had presentations from the team in Kilifi in Kenya around emerging evidence around anthropometry, and then what it looks like in practice for programmers and what they need in terms of evidence. So a very dynamic group. We did, as part of the build-up to the meeting, we collated what are people doing and where are they doing MAMI programming as a sort of a show and tell, and we compiled it into a document that we're just finalising. And this is just a little map of what we identified, where there is current MAMI programming going on and where MAMI programming is planned. And this isn't all of it, but this is what everyone contributed just in the build-up to the meeting. So it really shows it's happening and developing and evolving, and really shows a change over the last 10 years. What we did was, and coming out of this meeting, we identified very practical actions. We had global cafes where we had working groups and configured around 6 areas. And we now have action points around a common MAMI vision that ENN will be taken forward as the coordinating group with the London School. We have areas around terminology. There were several urgent technical questions that we examined in facing programmers, particularly around low birth weight infants, and there's a working group formed on that. We looked at indicators to help identify at-risk in infants, and so there was good conversation as a working group on that. Minimal data, again, a working group, and then key initiatives and stakeholders on coordination. We identified some MAMI champions and leads on that. So we've got a real, it was a very practical oriented meeting with some very strong action points, directions of travel, and enthusiasm to take areas of work forward. And so essentially, what began really as a MAMI interest group, really, I think I've likened to an Irish session where, a few people pulled chairs up around the table, got together and started heading a particular direction. And whenever somebody approached us, we said, "Oh yeah, pull up a chair, join in," and that's worked for us. And it's a very sort of been very iterative, sort of welcoming, collective and engagement. But we do need to formalise it a bit more. So we're moving more, trying to be much more of a bit of an orchestra, with a bit more structure, and also to manage this wider group that we now have engaged with it, but very much still seeing us as a supporting act to the main act, which is mother and infant at the centre, and really looking to national systems and structures. And really, we've seen a MAMI Revolution over the years we've been working on it, but really we're looking at trying to engender now a MAMI Revolution, and it harks back to that original vision that we had of a MAMI global network. And our vision is really, how do we maximize opportunities and harmonize efforts across humanitarian and development settings, generating robust, relevant research that's driven by country agendas and informs global and national policy development to ensures rapid programmatic uptake. And our work in Ethiopia is quite pivotal. I think, we've worked very closely at ENN with Ethiopia over the years. It's very much a hub of learning, and it shows direction, considers scale, it has strong government, and so and is looked to by other countries. So we really see this as a key opportunity for a country agenda to really inform global and national policy development. And we're very much linking and connecting in with the India development thinking and narrative, and connecting India with Ethiopia through this MAMI work to really try and not just pay lip service to this. And some of the reflections that we're having at the moment within the group is looking at the current reality. There's an urgent need for scale up if we look into the SDGs at 2030, but it takes about 10 years to get to scale. So we were looking at active tasks towards scale, which we're integrating in our research. There's a dynamic between a public health approach and clinical perspectives, and a need for these tools and integrated care pathways. And really the work that Kelsey is doing on our MAMI tool is very much about framing our approach to case management as an integrated care pathway that will resonate across sectors. We're looking at not just anthropometry, but functionality as well when it comes to outcomes. And we're looking at different disciplines. Treatment is not by nutrition alone. So essentially our idea is we want strong infants and strong mothers, where strong is survive, thrive, risk-oriented, and not by growth alone. And that links infants and mothers, hospitals and facilities with the community, links both with the anthropometry dimension, but also function, straddles nutrition and also engages on health and disability, and then crosses humanitarian and development divides. So that's your whistle-stop tour of MAMI at ENN. I hope you found that of interest, and we'd love to get your feedback and indeed your engagement on the area of MAMI. So always feel free to drop me a line at marie@ennonline.net, or contact our office directly. Our website is www.ennonline.net. The Brussels meeting report is now online, so if you hop onto our website, you'll see it there. And as I make these closing remarks, I'm happy to say that indeed we have secured funding for a scale-up of the MAMI Special Interest Group into a MAMI Global Network, thanks to the Eleanor Crook Foundation, and indeed we will have the continued support of Irish Aid in this effort too. So this will really mark a change and allow us to step up and really respond to the demands, the needs and the opportunities that we now have with MAMI, and indeed the challenges we now face in this new COVID-19 era. So again, a big thanks to all of the effort amongst all those agencies, those individuals who really have worked together, and I'm sure there's loads more we can do on this front. Many thanks for listening.